I think we're on our downhill slide from our COVID peak here in northeastern Colorado. It was pretty hot and heavy here from about late September until really probably early December. And then we've just kind of seen it slowly just kind of wither away. And we've had a few cases. We had a couple cases yesterday, probably some Christmas carryover. But things are much better than they were if you'd have talked to me in around Halloween. That's for sure.
Yeah. Oh, for the record, I'm talking to Dr. Tony Gerk from Sterling, Colorado, and today is January 7th, 2021. Good. So you said after we talked last, which was a few months ago, and at that time you were mostly just preparing and changing routines, but you'd seen very few cases. And then when did things start to change to the disease to increase?
I'd say kind of through September is when we started to see things things a little bit of an uptick. And then, as you kind of predict, this kind of exponential growth. And then really by early November was probably I think that was probably about as bad as we saw here in Sterling overall and in our clinic certainly. And then we had about 3 weeks, I'd say, where that's just about all we did. And then just kind of started to see this slow regression to where we are now, which is just we're back to kind of the sporadic cases that we saw kind of over the summer. So hopeful that's what continues.
Could you trace where your cases had come from? I know that Sterling, with the jail, you had one of the biggest outbreaks in the state.
Yeah, I don't think we saw a ton. We had some folks. There's a lot of people who work out there, but I don't think you could really link it back to that. I'll be totally honest. There is very little masking and social distancing here, and there really never was. And so we had our county fair was in late August or mid-August, and it was scaled back, but
it was still held.
People had events and they had parties and they had weddings, and so it just was kind of a predictable spread. And so we didn't ever really, I don't think we could ever trace it back to any one thing. I mean, I think it was just people were together. And so, schools, I'm sure, contributed to some degree, although we saw very few sick kids. But I think that's kind of like the national trend too. How many actual sick kids do you see and how much asymptomatic spread is there? It was funny. We were actually on Christmas Eve, we were sitting in church. And so we were in a small church in a small town outside of Sterling. And I was sitting there and I was, everybody, and I related to half of them anyway. And so I was just probably should pay attention more to what was going on, but I was counting the families and I was just counting which families had COVID over the last several months. And it was almost every single family in the church had it. And so, really, I'm very interested to see what happens here. I would love to know what percentage of our population in Logan County had it, because I think it was like astronomically high, just based on the phone calls we got and the number of our patients that, were presumptive positive or, tested positive and that sort of thing.
Yeah. I want to ask a question that just popped into my head. We all had to learn or if we didn't, we wound up going into pathology or radiology or something. But we all had to learn to, when our patients didn't follow our directions or did self-harming stuff, to just say, okay, that's the hand that we're dealt dealing with them. How was that for you emotionally, seeing all these people not masked?
Yeah.
As you have this deluge of sick people falling on your shoulders.
It was hard because there were, unfortunately, I think, and part of your biases started to come in there, but people who were very, very careful, people who were staying home, having their groceries delivered, they got it just as much as people who were without masks and those sort of things. And so it became hard to become accusatory to people.
Right.
And on the other hand, this has been going on since March. We can only keep people, you know, you can only tell people that something is terrible for so long before they start to say, I'm not going to do this anymore. And unfortunately, I think we went through a period from March until August where people here said, I've known a few people who've had it. There's unfortunately been a few people who have died from it, but I haven't seen it to the degree that everybody tells me that they're seeing it, or I haven't seen enough to make me as scared as everybody is telling me I should be afraid of it. And so people said, I'm not going to be. Well, I guess there's always people who are going to be, careless. But I think people said I can look at the world and I can evaluate what's going on, and I'm going to decide for myself whether I want to see my family or I want to get together for a wedding. And that's what people did here. People don't like to be told what to do. And also, I think people saw their lives escaping them. They saw months go by where they didn't see their loved ones, or they couldn't, hug their mom that was in a nursing home or what have you. And so I think at some point people said, we're gonna live our lives, and if we get a virus, we get a virus. And so that's what we saw. And so we tried just really hard not to be judgmental about that and say, if you get sick, we're gonna take care of you. And I'm not convinced that if we had locked everybody down, unless we had done a Wuhan and we bolted people within their homes, how much would we have changed what happened? Because we're here being very cavalier about how we're carrying on our lives. And I'm saying we because I'm part of this community. So not masking and having events and that sort of thing. And we didn't see anything different than what was going on in the rest of Colorado, where things were much, much different. So when I would drove to see my family in northern Colorado, in Fort Collins and Loveland and Greeley, much different scenario there. Everybody's masked, limited number of people within stores, things aren't open, and they saw the same.
Not in Greeley.
Yeah, well, right.
Or Weld County, I should say.
Yeah. So it's hard, and I try to just stay neutral on these things as much as I can. But I've really over the last almost year now realized, as much as we want to control people and we want to tell them that I know more than you and you need to listen to me, and I'm the one who knows this, and I went to school for a long time, and so I know more about the world than you do. That's just not the way things work. It doesn't work. And so ultimately you have to trust that people can look at the world and they can evaluate the risk for themselves and they can decide what to do. The hard thing is, obviously, we have this, halfway kind of socialized medical system where, yes, you can say, if I get sick, so be it. But then also that means you're going to go in and tax our medical system and our Medicare, payment system and all those sort of things. So we're in this weird world where, we're very independent, and we want to be free of anybody telling us what to do, but we're also dependent on a semi-socialized system to take care of us. So, such is life in America, right?
Yeah, I don't know if you followed the to-do with when was it the mayor of Longmont who said that people from Weld would not be welcome in their hospitals?
Yeah. Well, and I was just wondering how, thinking about, because we accepted some patients here in Sterling from other places, just there was a lot of patient shifting that went on, in December, November, if there were open beds in places or whatever. And I'm just trying to imagine if the mayor of Sterling had told our hospital CEO, you absolutely cannot take patients from other places, and like these hospitals that are trying to survive and grapple and have had a huge, loss in income. And I'm like, are they really gonna just turn away folks that need care? And I mean, and to cynically look at that, that's money for that hospital,
Right.
So yeah, I know that was kind of everything, the whole situation in a nutshell right there.
Well, so when you did accept patients from elsewhere, where were they coming from?
We had a couple from I know there was a couple that came from like Denver area hospitals, like
Really?
Yeah, then they needed, and it wasn't ICU, obviously we've got a very small ICU here, but it was like patients that needed more kind of like swing bed type, situations. We didn't take any new COVID patients. So it was like patients that I'm trying to think of what types of patients were accepted here. But it wasn't, I can't think of any off the top of my head, but it was just kind of routine things, patients that kind of had prolonged hospital stays and they needed to free up beds. And so I think we got a couple from like Thornton Hospital, a couple came from Greeley. We had a couple come from like like Holyoke or Yuma, which that makes sense because they're a little bit smaller than us. But then there was also a lot of shifting around here too. So when the nursing homes here had not had any COVID outbreaks until October, November. And so when that happened, they quickly got overwhelmed. And so then they sent patients out, to the other hospitals. So Brush and Sterling accepted patients. And so it was a real logistically kind of a crazy few weeks there with patients kind of going all over the place and kind of having a hard time keeping track of where your patients were. I had nursing home patients that I didn't really realize had been transferred. One went to Brush, and then one was in the Sterling Hospital, and one went out to Holyoke, and then several patients their family members had come and just taken them home. They said we're taking them home, and so it was hard to kind of know where everybody was, for a while.
Yeah. So when you were at your busiest, or when the pandemic was at its peak, tell me what a day was like for you.
Yeah,
A work day was like for you.
it's just an absolute deluge of phone calls. The phone calls were absolutely unbelievable. And our phone rings almost nonstop here anyway. But it was just unbelievable. And most of it, our front desk did an incredible job because they are, three receptionists up there, an office manager trying to, they're not medically trained. They do a lot of medical work, obviously, and we've kind of given them a lot of responsibility from a medical standpoint. They've learned a lot, but the things that they were having to navigate with people, and people did not want to be tested. They didn't want to, they were worried about having to be out of work, and my work is going to make me have negative tests. I can't afford to be out. What do I do? I don't want my whole family to be isolated and on quarantine. And those are really hard questions to, somebody told me several times, they said, "Oh, I'm so sorry you're having to deal with all this." Told me they were sorry. And I said, don't feel bad for me. We take care of sick people. That's what we do. If I didn't, if I wasn't able or capable or enjoying taking care of sick people, then I'm in the wrong profession. What's hard is navigating the social dynamics of this thing.
Wow.
And so when you test someone and say, okay, you were positive, and then their family is quarantined and they have to come home from school, and then potentially that classroom was shut down because the kid went to school for 2 days when the mom was sick, and then all this this snowball that happened, that people were just so they just didn't know what to do. And so that was hard, and our front desk people and our nurses did an incredible job of trying to just help people walk through that. And really, there wasn't no great answer. Just we would say, come in and we can certainly test you if you want us to test you. What you can also do is say, presume that you're positive and stay home for 10 days and keep your family home for 14, and those things. And so that was hard. And then we continued to try to not bring patients that were COVID positive or highly suspicious for COVID into our office. So we were still seeing some patients, and so we really just tried to see well patients during the day as much as we could. Our waiting room was not open. We didn't have people standing around. They checked in from their car and all these sort of things. And then anybody who was quote unquote sick, we went out to their car and saw them, or we tried to treat them over the phone. And so we kind of got this little protocol down pretty quick where we, would go out and do a COVID swab, and depending on if if their oxygen saturations were low, the nurses would draw labs and we'd check their inflammatory markers and send labs off and see how sick they were. And we treated a ton of people at home. We're trying to keep them out of the ER in the hospital. We recognized quickly that, really, if they went into the hospital, what they were going to get was dexamethasone and put them on oxygen,
Right.
and unless they qualified for remdesivir. And so we really realized, well, we can do that. And so we put people on home oxygen and we gave them dexamethasone if they needed oxygen. And we told them what to watch for, and we told them to buy a pulse oximeter and keep close track of it. And we checked on them once a day. And I think we did a pretty good job. And if they got sick, then we sent them over to the emergency room, or did a direct admit. And so there was just a lot of that. There was a day the nurses, the whole office was closed the Thursday before Thanksgiving. It's just kind of an office tradition here. And so I just took phone calls, and oh man, it was just nuts. I mean, I just took phone calls all day long, and it was just like this kind of phone triage, and okay, come in and we'll, we'll treat you, or let's see what your oxygen is. And um, it was wild. It was really wild. It was not something that I expected to see here, based on how things went all summer. But I think we got through it. And I think what we did is we just kind of like we were last summer, we tried to be as flexible as possible for our patients, and try to figure out how do we continue to take care of people? How do we do the best we can to help our local medical system not get overwhelmed? Let's not just send people to the emergency room, because I'm going to get on a small soapbox here, maybe a large soapbox, and talk about, I think there was a failure in primary care in a lot of places during the last 6 months, and this inability to care for patients that they thought were in any way, shape, or form possibly had COVID. If you have any suspicious COVID symptoms, we won't see you. We'll do a telehealth visit, or you have to go to the emergency room. And almost like people just put up this wall where I can't take care of that, or no, we can't have you in here, or I can't see you, or you need to go to the emergency room. And I think we did a huge disservice not only to our patients, but I think our emergency room colleagues, our hospital colleagues, by putting huge amounts of pressure on them to try to see all these people that we could have taken care of. And had we been a little more flexible as primary care physicians, and saying, okay, what are we doing in the hospital? What can I do for people? Can I get people on oxygen? Can I give them dexamethasone? Can I test them and do those sort of things, and not overload our medical system? I think we could have done a lot to prevent some of that overload that happened. And part of that, I think, was part of some of the big hospital systems just stopped allowing their primary care offices to see sick people. And I just don't think it was right. I think it did a lot of harm to patients. I think it created more fear, and I think like I said, I think it contributed to the overload of the hospital. So I think from a primary care perspective, over the next years, we need to do some soul searching about how, if we're truly frontline folks in primary care, then we need to be frontline folks, and we need to step up to the plate and not cower from these sort of things, and say, you know what, there's a possibility I might get exposed to this. But I'm going to take precautions. I'm going to do everything I can. But ultimately, I need to take care of the patients that look to me for help and advice, and to help guide them through these sort of things. And so that's something that really needs to be addressed. And I hope is honestly and ruthlessly looked at when we decide how we handle this pandemic.
So it seems to me that if anything, you're even more committed to the sort of taking care of whatever you can locally and yourself. I'm from that school too.
Sure.
Do you think it's going to change? Do you think it's going to change things? And let's not talk about the Front Range hospitals, for example. Do you think things will change, or have they changed in Sterling?
Well, I don't know. We still have the one of the big hospital groups. They are seeing sick people now. Another big hospital-owned clinic is not seeing any sick people at all, except for telehealth. Still, anybody who's too sick to do a telehealth visit, they send directly to the emergency room, or they call us and we see them. A small private clinic, not backed by a giant hospital corporation. We see them because we're going to try to take care of people. And then our federally qualified health clinic is completely closed. All they do is phone calls and parking lot COVID testing. Yeah, and I just think it's a travesty. I think it's a travesty. I cannot get my mind around this idea that at a time of need, at a time when people need us more than ever as primary care doctors, we have turned our backs on them and said, if you're that sick, you just need to go to the emergency room. I can't deal with you right now. I just think it's horrible.
Yeah, but that's how medicine has been changing, and
Yeah.
You have the choice since you run your own operation.
Mm-hmm.
Remind me, How many providers in your?
4. So there are 2 physicians and a nurse practitioner, a PA.
Okay.
Mhm.
Um, so you have that choice,
You're right. Right.
but medicine becomes less and less, more and more corporatized. I mean, even in, Sterling or Brush,
Sure. Everywhere. Everywhere.
everywhere.
I mean, I'm amazed when I even, similar story, but my brother and sister-in-law that live in Fort Collins, when one of their 3 kids gets sick, if they
Uh-huh.
call their pediatrician, they don't see them. They say, "Well, we've got an appointment, 4 days from now, but if she's got a fever and she needs to be seen, you'll just have to take her to urgent care." It's just incredible. And so they go and and that's they never see their doctor. They don't even see a physician or PA in the same office
Yeah.
for sick visits, which is just amazing to me.
So, but the other side of that, of course, is, if you take that responsibility and you do that work, that's just it. You don't get to put it off on someone else.
Hmm.
Um, it sounds like it was really crazy there for a while.
Hmm.
Um, how did you and your staff and partners hold up?
I think we just kind of we kind of we just kind of circled the wagons. I think it's kind of like I probably said the last time we talked. We said, okay, this is what's going on. We got to take care of these people. I mean, I think each of us had our moments. We each had our kind of moments where of oh, not weakness. I don't know what the answer is. Kind of a breakdown type moment.
Sure.
I hugged our nurse practitioner one night when there was just so many sick people, and we were just on the phone talking to these older folks that we were trying to keep out of the hospital, but we didn't know if were they gonna get sick and not. And it was stressful, and there was a lot of worry. And then one of our front desk girls, she just had a day where she really just broke down and said, I never thought I would see this. I never thought that this would happen like this, and so I think we all went through our kind of process of kind of, at first it's like it starts to happen, it's like the slow wave, right? You're like, oh, I think this is kind of getting serious. And then all of a sudden, before you can kind of blink, you realize, oh my gosh, we are in the thick of it right now. But I think the other thing was having some perspective too. We saw how hard the people at the hospital here were working. We saw what was going on in the emergency room. And then we also, the perspective of seeing families that lost their loved ones, and seeing sick people. I mean, not to say you can't have some self-care, but I think we all tried to keep in perspective, hey, we have to be strong right now. We got to take care of folks. And not that we can't express our emotions and mourn when we need to, or feel overwhelmed, or
No,
talk
you
about
have to.
out. But people need us right now, and this is like our time to shine. This is our time to say, we've got this, and we can take care of you. Call us when you need us, and we're going to be here for you. And so I think that I think we also felt like we were doing a lot of good. I think every single person in this office recognized when they talked to people, even if it was just reassuring someone, if they talked them through, what they needed to do, or how to take care of folks, if we saw them, if we got them in, people recognized more than ever. I mean, I think we're affecting people's lives every day here, but it was very evident at that time, and people were incredibly thankful. And it was a really, for me, I thought it was a really fulfilling time. I mean, even though it was overwhelming and I wanted it to be over, it was one of those days where you drove at the end of the day and you drove home and said, man, this is what we should be doing. This is it. We should be helping people through this. And I think we are.
Yeah. In my experience, of course, the hardest things are like the issues like you talked about, where it doesn't matter how good your training was. The issues aren't about things that are definite.
Mhm. Mhm.
Um, when it's how does this fit with which is exactly what we try to be good at, but
Right.
how does this fit with this particular patient's person and family and situation at this time, and how do we, and no two are the same.
Yeah. No, they never are. That's the hard thing, is there was no treating people wasn't too hard. Their medical problems, but the social situations, answering the questions, there was no cookbook for that. It was unique to everybody. I was sick a week and a half ago, and now my mom is really sick, and I want to go see her. Can I go see her? I don't know. My daughter's, was in school with somebody yesterday who has COVID, but if she's out, then I have to, be out of work for 2 weeks. And, those things were just crazy. But that's life. I mean, that's people. When we're taking care of people, we're not taking care of widgets. We're taking care of people with real lives, and that are unique, and every situation is different. And so, I think if that's part of why we do primary care, right? If we want something very regimented and easy, not easy, but very you just check the cut and dry, exactly. Then you go into a different field. It's so nebulous.
Particularly when I would talk to medical students about what specialty they were thinking of pursuing, I would tell them that I think that the personality characteristic that is most important for going into family medicine is the ability to live with uncertainty.
Yeah.
The nice thing about that is that there's always somebody who knows more about it than you do,
right.
And so you get stuck, and you can get help.
Yeah.
But it's true.
Yeah. We had a nurse practitioner who worked for us for almost a year, and she decided to go back to Denver, but that was a really hard thing for her. The uncertainty of, she had done acute care nursing,
right,
and for like 5 years before she went to NP school, and this whole idea of like, I'm going to send somebody home and I don't know what's wrong with them, and it could be something bad, or it could be nothing, and we'll do some labs and we'll bring them back in a couple days, and so that was all encapsulated, the last several months too. I mean, people,
and that might be 70% of our patients.
Yeah, right, exactly. That's exactly right. Yeah, for sure.
When I was an intern, I had this saying posted on the mirror of my call room, and it's by a Spanish, lived at the beginning of the last century. He was an endocrinologist and a historian and a philosopher and a writer, pretty amazing guy named Gregorio Marañón. And he said, "No hay enfermedades, sino enfermos," which means there are not illnesses, only sick people. And
isn't that true?
It grabs it.
Yeah, absolutely.
Now, have you been doing hospital too now?
We never, I never had to do any adult inpatient, but I do, babies and moms, and then we do pediatric admissions. And so, but no adult admission. So, I haven't had to do any of that. We kind of had our, the hospital's protocols for who would be called upon when, if we got overloaded and stuff like that, but we never got to that point.
Have you delivered babies in the course of all of this?
No, so many.
And how has that been?
So, it's been a little bit of an adventure, only in that, like everything, things change like every day. And so, it's like, okay, what's our protocol now? Oh, we're testing them. Oh, we're not testing them. Oh, we have to test them beforehand. No, they test them when they get here. No, we're not testing at all. Oh, we're wearing N95s. Oh, we're only wearing N95s when they're pushing. Oh, we don't have to do that anymore. It's like everything is just trying to be like flexible, and like, everybody's just trying to do the best they can. For me, I think it's been kind of a welcome, like, relief from it. Just like delivering babies almost always is in primary for me. Even though it's like the most stressful thing I do in a lot of ways, it's just like almost a universally happy thing.
Yeah.
And so there's been so many babies born. I think we're kind of starting to see these quarantine babies now showing up, of people being stuck at home. And so what do? We have babies. And so, we've we've delivered a lot. In fact, October, November were incredibly busy. And so, we try to navigate it with patience. And, one thing we kind of were worried about here was that we would get to a point where moms were not allowed a support person in with them during delivery, because we heard about that. And so there's 6 of us here who deliver babies, and so we kind of had a powwow about it, and we just kind of said we're not going to allow that to happen. And so whether it is right or wrong from a infectious disease standpoint, there are things that
Yeah.
this just should not be allowed. And so we kind of, in a roundabout way, said, if what is happening at other hospitals happens here, then you'll have to find a new set of doctors to deliver babies because we're not going to be part of that. And so we never luckily got to that point. Moms were always allowed to have a support there, the father or another support person with them, which I think was always reassuring because there was tons of questions from pregnant women. Am I going to be able to have somebody with? What is it going to be like when I go into the hospital? And especially for first time moms, it's also unknown anyway. And I just can't imagine having to help these poor women, tell them, leading up to delivery, you're going to have to do this all by yourself. I know you've never been through this before. I know you have no idea what's coming, and you're going to have to do it all by yourself.
So here's what I get to pull out my old fart credentials. I mean, when I started, that was how it was.
Right. Yeah, they just did it by yourself.
It was because I started medical school in 1970, and it was in the 70s that the feminists just started insisting, no, this is about the mother, not the doctor.
Yeah.
But that's well, I could tell you all kinds of war stories about how
right.
But
yeah, so that was hard, but I think that, like I said, and then because we deliver babies, then we take care of those babies, and so we have this constant trickle of new parents bringing their babies in for their 2-day well child checks, and so all that we kept because we've got to see those folks, and so and I think so that was a little bit of a reprieve, I think, for a lot of us, is to despite the kind of fury going on outside the door, you could close the door and be in with new parents and talk to them about their baby and help them with feeding and I'll answer those questions.
When you stress a group, of course, cracks can develop. And so looking at the larger picture in Sterling among your colleagues, how have you all done? I mean, I can see like you said, a couple of practices pretty much just kind of dump their sick patients on the hospital and on you. How has that gone? Are you managing to hold together pretty well? Are there now factions and divisions?
I think the good thing is I see medicine like kind of it's kind of going to it's physicians versus administrators. And so that's kind of how it is in Sterling. And so we all share call, like even between practices, there's just one call group for the whole town. And so we all work really closely together all the time. And so, like, from my perspective, I've tried to work really hard to not, be judgmental about what other doctors do because their administrators are telling them that's what they have to do. That's just how it is. And so I can't be mad at that physician because his administration said you can't see sick people. Whether he or she wants to see them or not, they're not allowed to see them. And so I think from that standpoint, there hasn't been any of this like, well, you guys are just dumping it on us, or and so I think we've all stuck together pretty well. I think there's the, just like there is in the whole world, there's the differences among physicians, the personalities of physicians. How terrified are we? Are we living our daily lives, safely, or are we so petrified of and scared of COVID that we are, can't even fathom being in the same room with somebody with COVID, or and those sort of things. And unfortunately, there's a few physicians that they're very scared of it, and so I think we've just tried to support them as much as we can and say, well,
that's good. So the collegiality is holding. How about and I know it's difficult, well, you guys still get to the hospital for your peds and OB, but I think that's something that was lost too, that has been lost in so many places when you have a different group of people caring for inpatients and ER.
Yeah.
I started it out and even my in brush for a long time. I was doing it all.
Hmm.
And then we had ER, and now they have inpatient, which is like inconceivable given where I had come from. But you lose track of those people.
Yeah.
Hey, have you been? And now also with the isolation, I mean, you can't stop for a cup of coffee or a beer,
Right. Yeah, that's
or
hard.
hang out in the doctor's lounge, or
Right. Or going in to see patients. Like we still, so like we have a hospital service, but I'm always over at the hospital all the time anyway.
right.
So, I always stop in to see my patients that are admitted. How are you doing? Checking things. And so you can't do a lot of that because you don't, there's not the in and out of rooms. You don't want to expose them to anything. There's the COVID-free areas and stuff. And so that's been hard. And then, yeah, and then, meeting, this is how we meet. Like all our hospital meetings are like this now. So, like yesterday we had our med exec meeting, and we're going to go back to an in-person meeting next month. And there was like this like round of applause, from all of us, because there's a big conference room where we can all be kind of spaced out. We're going to have an in-person meeting next month for the first time since March. And so everybody's just so excited, and so that's because there's those little things, and it is kind of sad. I mean, it's good and it's bad. Our meetings are very efficient now. We're like done with them in like 3 minutes because there's no like nice chit chat and camaraderie. It's just like we just go through we do the business, and some people I can see their face, but other people don't have their cameras on, and it's just all those little things that kind of bring you together as a medical staff have been put on hold for a while. So that's hard. I think there's doctors that I haven't seen for several months, even though we're like 500 yards apart, because you just don't interact that much. So that is hard.
So you have a position in the medical staff now. You have on the medical executive committee. You're an officer, right? What's
Yeah.
your position?
Well, so I was chief of staff. So I was supposed to be chief of staff for 2 years, and I ended up having to be chief of staff for 4, because yeah, people leave and whatever. So now I should be the immediate past chief. So the past chief of staff stays on for 2 years to kind of help support. But we also had another person leave, so I'm also the interim vice chief. But I'm not rising back to chief of staff in 2 years. So we're trying to create a succession plan that will work, a peaceful transfer of power at some point. So we're so I'm right now past chief / interim vice chief. So whatever.
Now let me make a quick editorial comment to put this in a date. Yesterday, January 6th, was the day that a mob took over the Capitol building, which certainly will appear in your history books.
Yeah.
You'll read about this if you're looking at these videos years from now. So that's what that peaceful transfer of power is.
Right,
trying to stop the inauguration of a new president, but President Biden after Trump, but it's happening. So
yeah, right.
It's chill, as my kids would say.
There you go. There you
go. As a medical executive, or as an executive rather, of the medical staff, and of course the hospital, have there been efforts made to support staff and medical staff that have been meaningful?
I think there's been, I don't know. I'm trying to think of specific things that have been done. I think our CMO here for the hospital has done a good job of kind of reaching out to people just to kind of check in and see how they're doing. He's done a good job. That's Jeff. Yeah. Just to make sure that everybody is hanging in there. What do you need and that sort of thing. I think that from an something formal, there hasn't been anything too formal that's come, like let's say specifically from the administration side of that sort of thing. Mostly because I think they're just so overwhelmed. I mean, that every day is a new day of trying to sort out how do we navigate this, how do we stay, kind of financially viable and that sort of thing. So no, I'd say there probably hasn't been as much as there could have been, or maybe should have been. But I also don't think that there was, I don't think any of us saw a giant need. I think if we had seen our medical staff starting to like fracture, or that there was a real morale problem, that people were really starting to struggle, more systemic problems rather than, just kind of individual people having a rough time, then I think then as a medical staff, we probably would have done more. But there wasn't a ton. There wasn't a ton of that.
There are things that you've done to um, bolster people, to bolster morale outside of just doing the work. And
Yeah, I think we've tried to just kind of, when we have an opportunity to do good things, nice things for everybody, so when the restaurants closed down for in-person dining, a month and a half ago, we decided that the providers decided we're just going to buy lunch for everybody, the whole office, every Monday, and support the local restaurants that need the business, and then also, do something nice for the staff and have lunch for everybody. We decided to have a Christmas party. So we said, we are, it's not like we had tons of outside people, but we are all together all the time. And so pretty much anything that I have, my staff has. And so we said, is it okay for us to have a Christmas party? And we decided yes. And we didn't have it at a restaurant. We didn't go, in a place where we'd potentially all be exposed or expose to other people. So we went to, luckily we live, out in rural Colorado. So people have big barns and shops and that sort of thing. And so we were able to just kind of have a small get together with our office staff and their families. And enjoy kind of a night when we haven't been able to, wouldn't otherwise be able to do those things. So I think we've looked for ways to try to keep people happy. Everybody got really nice Christmas bonuses. So, financially, those things can help a little bit.
And how are you doing financially through all of this?
We're doing good. We really are. I mean, we surprisingly, we were really worried about things when we really shut things down a lot, in March and April. We were worried about kind of how our accounts receivable and stuff were going to look in the summer, and we navigated through that luckily, with a variety of things, payroll protection and some of the local grant money that was available. Medicare did some of their advance payments, and all those things really helped a lot. So that got us through those periods, and then we kind of began to pick things back up. We had added in telemedicine. We were still delivering babies. And so, that stuff, that financial, that kind of pipeline didn't stop because of COVID. And so we've done actually really well. We hired a new physician in June, which is kind of a scary proposition, in the middle of all this. And he came on and it's gotten busy right away. And so thankfully, we're very thankful and lucky to have kind of weathered this storm pretty effectively.
Was he newly minted? Your new
So he had been here in Sterling for 4 years. He and his family moved abroad in early 2019 maybe, and then they got kicked out. They were in the Middle East. They got kicked out when COVID hit, and so all kind of foreign nationals were required to leave, and so they came back and decided they were going to stay here permanently. So he had been working when they lived here. He had worked at the Banner Clinic, and then when he decided to come back, we quickly snatched him up. It was kind of an opportunity that probably, I don't know when it'll ever come along again. Somebody that I'd worked with for 4 years, also delivers babies, well trained, well respected. His wife grew up in Sterling, so they've got ties to the area. And so we realized when he was coming back, we needed to and do everything we could to hire him, and it's worked out.
That's about as good as it gets.
Yeah, really. I mean, it couldn't have been any better.
So speaking about financial and responsibility, that's the other thing about, of course, having your own practice, which I've also done. That adds a whole level of concerns and work.
Yeah.
Has that been, and you've had these things, and you've had to negotiate the payroll protection and so on and so forth. So that's been added on top of all the rest of this stuff.
Yeah, it was hard. It was harder early. I think now things are we've kind of sorted things out, and so it's okay. And Megan, our office manager, was able to kind of stash away some money in the summer to kind of have as a if needed fund and that sort of thing. But that payroll protection, that was a really stressful time because if you remember, that first round of payroll protection was just quickly gone, and we had been banking with a big bank. So in Sterling, has a branch in Sterling, because Dr. Clark, who founded this practice, had been with them since he started, and they gave him his initial business loan, in 1977 to open the practice, whatever. So he had felt this obligation to them. Well, then when it came to payroll protection, and our small little practice went to them and said, "We need you to help us get this," they said, "We're never going to get to our small businesses. You need to find another bank." And all the local banks here were helping their own customers first. So we were completely left out of the first round without a question. And then the second round, the money was quickly going, and the bank that we had gone to for help was not at all helpful. And so we realized that they were not doing what they needed to do to get it done for us. So I called, just luckily have got some friends that are patients that works in a bank, and I called and I said, "Oh my gosh, is there any way you can help us out? We're really, I don't know what we're gonna do." And they did it for us. And guess what? We moved all our accounts to their bank, and so that's the way things work. So yeah, so that was stressful. And then just worry. I think the worry about, are we going to be able to make payroll? Do I need to not take a paycheck for a week or two, so that we can make sure that everybody's employed? Because early on, we decided we needed to keep everybody. We're in the medical field in the middle of a pandemic. We can't lay people off. How does that make sense? And so we were like, we have got to keep people employed so that when and if things get bad, we've got the staff that we need. And so just the worry about, was it gonna be possible to keep everybody employed? That was a lot. That March and April, I don't want to go back to that time again. That to me was worse than October and November for us. That uncertainty of it, and nobody knew about COVID. That was the other thing. How do we treat it? What are we doing? Are we giving them hydroxychloroquine? Is there anything that works? And this was much different for us in November. We knew there was some treatments. We knew what to do and what not to do, and so that was much more straightforward. But that uncertainty of March and April for me was that's not something I want to revisit again.
Have you lost many patients to COVID?
Yeah, not a lot. Nursing home patients, we lost several nursing home patients in a 2-week period. A couple just tragic. We had a couple just, as it is, the nursing home patients, and not that any life is more valuable than the other, but
yeah,
when our nursing home patients pass away, they, unfortunately, old folks pass away. We had some younger people that died suddenly that were just tragic for us. We had a 62-year-old gentleman that he did not take very good care of himself, but we saw him a lot. All of us knew him well. And he got COVID and was actually doing better, never needed oxygen. And then about 10 days after his positive test, was home with his son, got up to get a glass of water and collapsed and died. And I'm sure in retrospect, he had a clot. And that was before the kind of recommendations of that. It was early. That was really early in our peak. And it was before the recommendations for aspirin for people that were, moderately ill and with risk factors and stuff like that. And so we hadn't done that for him. And so, those sort of things, that was hard. We had a patient who he had an arterial clot in his leg and had to be transferred to Greeley. And he was there on the vent for like 6 weeks, and we were following him closely. And his wife had just finished cancer treatment when he got sick. And he ultimately died. And he was in his late 50s. And so there were some of those that were really hard to deal with. There were some that and so we, I don't know. The thing that I think in primary care, especially family medicine, we're comfortable dealing with death, and so because you see it so often, and so you're comfortable talking to people about it, and especially patients and family members, and reaching out to them to make sure they're doing okay. But and it seems like we always go through periods where we'll have a few weeks where, oh my gosh, what happened? Why do we have had like 4 people die in 4 weeks? What's going on here? But to have that period of time, for about 6 weeks where, several people a week were dying in our practice from one thing or another. It just, we do sympathy card. We send a sympathy card to all the families of our patients, and our office manager would bring out this stack of sympathy cards every week, and we were just like, oh my gosh, here we go again. And that was hard. That was hard.
I, just to put a frame around having your own practice, which, as you describe what you're doing, I feel a little jealous. I'm not about to leave retirement, but um, I learned this way long ago. It was about risk factors for coronary artery disease, and they said that absolutely the worst possible job would be to be an athletic coach, because you have all the responsibility and none of the control. You have a huge amount of responsibility, but you have the control.
Yeah.
And that makes it that makes it less toxic.
That's 100% true.
Yeah.
Yeah. And we value that so much, and we try to impress that on the folks that work for us here, and let them, make them part of the decision making process, and try to be flexible, and I think you're exactly right. Knowing that you can control things, that we can adjust and adapt to do what's best for us and for our patients is it's priceless.
Yes, I agree. So anything else?
I don't think so. I think we on a personal level, where my wife and I are also going to have a quarantine baby. So my wife is going to have a baby in June. So we're going to now have 4 children.
Wow.
And so we've got a lot going on in our house. And she actually had COVID in middle of November, unfortunately, and did well. She was 12 weeks pregnant, but she did great. And she's a CRNA, so she's been working hard at the hospital and intubating. They have CRNAs intubate all the COVID patients. So she's been working hard too. But we've kind of tried. I think we've done a good job of holding everybody together, and our kids are back in school. And like I said at the beginning, I feel like we luckily are I think on the downhill side of this, and there's some real satisfaction in saying, we survived. We did some good. There's probably some things we should have done differently, but if it happens again, we can handle it.
And are people getting immunized now?
Yeah, slow. It's been really slow out here. I just got the first round of vaccines were available last Wednesday. That was the first time we had vaccines available out here. So I got mine last Wednesday, along with most of the folks in our office. And then the hospital employees, I think, started. They're kind of getting it now. And then I haven't heard when the health department will get their next round of vaccine in. But I think most of the first responders in the medical community has been vaccinated at this point. So slowly but surely.
While I'm at it, I realize we'll run over a couple of minutes probably.
You're fine.
But KHEC has along with the state AHEC begun in rural Colorado. We're working on getting a vaccine acceptance program out there. Probably some videos that'll be on YouTube in English and Spanish, and we don't know what else.
Yeah.
So let me pick your brain about this. Have you heard a lot of resistance to vaccination?
Huge amount in the fall. And then I think a variety of things. So seeing COVID firsthand in the community, everybody knowing somebody almost, that had it, almost everybody knowing somebody who died from it in a small town, really changes your mind and kind of adjusts your risk tolerance, for things. So we've seen more acceptance there. And then I think as the medical community, as all of us have gotten more comfortable with this vaccine, because I'll be honest with you, I was quietly skeptical in August or in September when they said, "Oh yeah, it's a brand new, it's a brand new vaccine. It's an mRNA vaccine. We've been working on it for a while, but we've never really used it, and we think it's good to go." So there's part of me inside of me says I have trust for this process, but also, do I? And so I think as all of us have learned more and become more accepting, then we've seen more acceptance from our patients. There's still a large segment of our patient population, I'd say 60%, that right now, if you went to them right now and said, "Here's your vaccine, do you want it?" Overall, so I'm talking young people, old people, I'd say 60% would say no, not today.
60%.
I would say yeah, for sure.
Whoa.
And then, but I would have said, honestly, 2 months ago, I bet it would have been 75%. So I think we're making some headway. And I think when push comes to shove, when folks, I got my vaccine last Wednesday. There was a picture of me getting my shot, and
Good.
my little card, and we put it on our Facebook site, and it was amazing. I didn't like, I don't know how much you do Facebook, ads and that sort of thing. You can boost when we post something on our office website. We can boost it so more people see. I didn't boost this. It was an advertising thing, but it was shared. I think it was shared by people 142 times. It was seen by 7,000 people, and I think like 300 people liked my post because what I did is I had a picture of me getting my vaccine and an explanation of why I got it. And
Well,
so that was that I think those little things have helped.
one of the strategies we're talking about is engaging the practitioners themselves.
Yeah.
In promoting this and helping them to do it.
Yeah.
Is there anything you could? One thought we even had was it's going to be just a little 3-minute video.
Sure.
But then with space at the end for you to add your
Your
2
own
cents.
little, your 2 cents.
Because of course, if it's somebody especially rurally,
Yeah.
it's more.
I think part of it is it's just like any vaccine battle. This is like prime for the anti-vaccine folks, right? And then there's so many conspiracy theories anyway about COVID, and then you add on a vaccine thing, and these anti-vaccine folks are like, they're just salivating over this, right? Like a brand new vaccine that's been put out quickly for a virus that, whatever. I mean, it's just like, oh, it's just ripe for it. And so, and then it's, we're injecting in genetic material, that's great too, and so I think there's all these things that just, when people get these snippets of things, and I heard time and time again from people, oh, well, they're injecting that genetic material into my DNA. And I'm like, no, that actually that's not how this will look. Let's talk a little bit more about it. And so that's what I tried to do, obviously in short form in my Facebook post. But you just gotta, I think people just kind of slowly hearing the message over and over again, and then also seeing that the people that they trust are getting it. I think that is the most important thing too. There's going to be folks who never get vaccines. We can't do that, but I always have the opportunity. We don't kick people that don't vaccinate out of our practice, because every time our philosophy is, every time that parent brings their child in, that's an opportunity for me to talk to them and hopefully help them understand why they should vaccinate their kids. If I kick them out, then we're never going to see them again.
Right.
So and so I think it's the same way here. It's just slowly chipping away. Hopefully the people that they trust are the ones giving the message. And so I think, especially for rural Colorado, the more local you can make it, the better, and so trying to personalize it for communities, or like you said, having that snippet at the end or the beginning and the end, to say, hey, here's your local physician in Yuma, and he wants you to watch this video or whatever it is, so it'll I think people will, more and more people will get vaccinated. I don't know what it'd be very interesting to see what ultimately the percentage of vaccinated people will be in these communities.
Yeah. All right. Well, if you think of anything,
Yeah.
and I may well contact you about this
Sure.
at some point. All right. Well, I really appreciate your doing this, and this is very, very helpful.
Great.